managing neonatal anemia without transfusion. Definitely an emerging topic and one of critical importance. I have no financial interest or conflicts to disclose, and I really won't be talking about anything off-label or out of approval during this talk. So my goals and objectives for this morning, I think when we look at neonatal anemia and the issues that take place right after birth, I think I break it down to three parts. One is, how do we get here? How do we get to having babies who have anemia? I know many of them are physiological. We'll go through the causes. And then once you are anemic, is like, how do we get back? How do we, instead of getting lost, how do we, once they are anemic, what can we do? And what can we provide for our patients and the babies in our NICUs to go from being anemic to having a normal red blood cell count and hemoglobin? And more importantly, that's where the traffic management comes up, is how do we not get lost the next time? How do we take babies who we know are potential to be anemic, and really that includes all babies given their physiologic changes, but more importantly, our preterm babies, our other babies at risk, how do we not get lost next time? What can we do right after birth in our treatment plans, in our treatment protocols, to make sure that patients do not get to a point? Because, and this will come back to you throughout the talk, unfortunately, there are certain levels of anemia where we know we can allow babies to fall to, because we know that there are going to be severe neurodevelopmental outcomes. And that's always the key point here. It's not particularly what happens in the moment for that baby. It's what do they look like, as I tell parents all the time, 2 months, 2 years, 20 years down the road. So we're going to go through some of these different parts and see where we are right now in our practices. So neonatal anemia. So the first question we always have to say is, what is it? How do we define it? It's definitely different than in adults. I'm not sure how many people are pediatricians or neonatologists or work in neonatal units on this talk, but clearly, obviously, we all know it's a low number of red blood cells in circulation. And at birth, right after birth, for term infants, we're talking about 14 to 24 grams per deciliter. In preterm infants, it's slightly lower, and obviously this will depend on gestational age, and we will go through that, but 12 to 20 grams per deciliter. But that's the textbook definition. All of our patients do not read textbooks. And many are lower, given the cause of their prematurity. It could be maternal issues such as sepsis or preeclampsia, and there could definitely be issues intrinsic to the baby themselves, and we'll talk about those in a few moments. So when we talk about anemia in neonates, we're talking about the first 1 to 2 months of life. The official definition of a neonate is 28 days, but I think if we look at it, especially with our preterm patients, of being 1 to 2 months of life, that's a good way that there's definitely physiological changes after that kind of put them into more of the infant and toddler category. A significant, as we mentioned, a significant drop in circulating red blood cells and hemoglobin, and culminates in what we call the physiological nadir. In term infants, you're talking about 10 to 11 grams per deciliter. Preterm, again, slightly lower, 9.5 grams per deciliter. And that is when we talk about physiologic, that is how the body is designed to work, and how the baby is actually designed to go through the processes from fetal life to extrauterine life. So why does this happen? Why do we have a physiologic nadir? We have what we call, like I said, physiologic. There's anemia of prematurity, which is just a decreased production and a slower production in our preterm infants. And overall, the red blood cells in a newborn, the lifespan is lower. It's only about 60 to 90 days, which puts you into that 1 to 2 month period for seeing a physiologic nadir. Other causes, and we'll go through other, iatrogenic, meaning phlebotomy, just actual excessive blood removal for testing, could definitely cause a role in a neonatal anemia. And then we have the pathophysiologic. We have different categories of blood loss, such as fetal. So these are things that take place really pretty much right before and during the labor and delivery process: fetal maternal hemorrhage, twin-to-twin transfusion. If a mother is a placenta previa and has bleeding, has an abruption and has bleeding, all things causing a loss of blood volume from the baby. Other things, increased destruction of red blood cells. The most common are the immune-mediated ABO and RH disease, which could be both chronic and acute or chronic loss of blood. Illness, any form of illness in both baby or mom can lead to a decrease and a more significant neonatal anemia. And nutrition, both in maternal nutrition and fetal nutrition, and we'll go into some of those details momentarily. So physiologic jaundice. So take a look back as to why this takes place. In fetal life, erythropoiesis is active. It's 3 to 5 times greater than we see in adults. They're constantly fetuses are making new red blood cells. However, at birth, you have a significant, almost 2 times increase in arterial oxygen saturation. As babies are disconnected from the placenta, those levels go up. And then there's the negative feedback, as we know, on EPO production within the baby. So increased oxygen saturation and the negative, and then EPO production goes down. You have our reduced RBC lifespan, 60 to 90 days. And in addition, those RBCs are more prone to oxidative stress, hemolysis, and being taken out of circulation earlier. Hemoglobin, fetal hemoglobin levels are higher. They're not as productive in oxygen delivery and other forms. And then there is some form for hemodilution, increase in blood volume following rapid weight gain. It's not clear exactly how much that plays a role, but these are the reasons that we would see a physiologic nadir both in preterm and in full-term infants. However, in preterm babies, there is some differences, and given the fact that our preterm babies overall are at increased risk for neurodevelopmental delays, they definitely play a much longer role. There's a correlation between gestational age and postnatal hemoglobin. The earlier you are, the lower your hemoglobin levels are going to be. So now our most significant, our most stressed, our most at-risk babies are starting from even lower levels. EPO production. During fetal life, during the pregnancy, fetal hemoglobin erythropoiesis takes place in the liver at about 32 to 34 weeks gestation. It switches to the bone marrow, it switches to the bone marrow, and then we see that in full-term babies. However, in preterm babies, obviously, those who are definitely born 24, 26, 28 weeks of gestation, they're going to remain in the liver, and the liver is less responsive to hypoxia. So, and these take place even post-delivery while in the NICU. So as the need for more RBCs, as these babies have their lung issues and lung disease, their bodies are not making as many red blood cells and not trying to correct the anemia on their own, and therefore putting them even at risk for even more significant levels of anemia. Additionally, during the preterm life, there's accelerated clearance of EPO, or erythropoietin, and it puts them again not making as many RBCs and not being able to correct themselves in the face of both preterm and as well as in the face of increased, as we mentioned, destruction and other issues that cause the anemia to be more significant and severe. So the pathophysiologic causes, so we know that 2 of the more common ones are ABO and incompatibility and RH disease, always mixing of blood, and we see that antibodies from mom are passed on to the baby, causing red blood cells to be destroyed as they're confused for foreign invaders. Nutrition, there are nutrition deficiencies in premature babies, both caused from being premature and as well as from the inability sometimes to feed post-delivery. There's a significant increase in cyclical accretion of many vitamins in the last 2 months of pregnancy. Those babies who are premature do not have that period of time to get certain vitamins and minerals from mom. Babies are deficient in iron and B12 and other vitamins. This is not even including vitamin K, which we could talk about at a different point. But this is other things that put the babies at risk for just not being in a healthy state and not able to correct the anemia on their own. And then illness. Premature infants as well as full-term infants are at higher risk for illnesses. They're immunocompromised. Sepsis and other forms of illness, it could definitely play a role and put them at higher risk of basically decreased homeostasis and inability to correct the anemia on there as well. Other things which I'm really not going to go into so much about in this talk are hemoglobinopathies, spherocytosis, elliptocytosis, which are going to have increased levels of anemia. One thing that I didn't mention, I should have put on the slide, is G6PD deficiency, where you get an increased anemia, and all those will apply as well. And iatrogenic, meaning, obviously, we all know as what we cause. So a newborn infant has a blood volume of approximately 80 mLs per kilo. So you can imagine in obviously a 2 kilo baby, that's 160 mLs, and a really small baby, 80. And sometimes in our babies who are born 500 to 600 grams, you're talking 40 to 50 mLs total of a blood volume. And especially in the 24 to 26 week range, significant number of blood draws that take place while they're under care. ELBW, extremely low birth weight, and VLBW, very low birth weight, are at increased risk. The sicker you are, the more tests people are looking to do. They include daily CBCs, basic metabolic profiles, bilirubin checks, blood, and which will withdraw. And one definite significant one is blood cultures. The amount that you need for a blood culture to have a true test is going to be a significant amount of blood, 1 to 2 mLs, to really be sure that you're having an adequate sample size. And to keep taking that out of a baby, 40, 50, who has a volume of 40 and 50 mLs, you can just imagine how you keep lowering and lowering the amount of available blood, and then the worsening already predetermined anemia. So how do we go back? Once we have a baby who is anemic, how do we go back to get them into a better state? So transfusion, and I know we're talking about managing without blood transfusion, but there's a couple of things we need to mention. First, and we'll go through a couple of cases and studies. There's no evidence-based guidelines as to when to transfuse a baby. Most of it, almost all of it, if you look through the literature, is based on expert opinion and dogma, anywhere from a range of having a hematocrit of 25 to 41%. And as I was once told by a surgeon, if there's more than one way to do something, none of them are right. When we have a situation where we know, where we have a treatment, and this is the treatment that you should use, everybody follows it. You have appendicitis, almost always you're taking out the appendix. If you're having a range of hematocrits of when you would transfuse, and you're having different ways of doing it, it most likely indicates that there's no clear evidence one way or another, which is the correct path to choose. So I know we all spoke about bloodless medicine, and I'm a huge proponent, as Sherry Oswald said, I believe that is the safest way to treat all of our patients. I want to try to turn away and try to convince colleagues to turn away from transfusion. So this study, and this slide is about from a study from Guillen in 2012, and they were looking at thresholds for transfusion. And I put this slide up there to illustrate a point. This is looking at, and this is from surveys, an international survey for transfusion practices. And what you can see, and on the x-axis you have certain aspects of where a patient is up to, whether how much oxygen support they are, if they're needed to have mechanical ventilation, and when you would transfuse based upon a threshold of hemoglobin. And what you can see is that there is, by these wide ranges, and when you're talking about a baby with a 50 to 60 ml blood volume, anything between 10, as again on the far left, 10 to 12 grams per deciliter, there is no consensus as to when the transfusion is needed. Perhaps there's some with mechanical ventilation, but you can see the wide ranging of views throughout the field of neonatology and dealing with neonatal anemia and when you would have to transfuse. So additionally, there was the ETNO trial in 2020, and they looked at a liberal versus restrictive transfusion threshold. And hopefully you can see the content, the slide over there on the right. The liberal use anything from from about less than 41 at birth to less than 34 at 21 days. If you're critically ill, anywhere to less than, and for a restrictive view of less than 21 for a non-critical health state. And they took a look at different outcomes for these patients. The primary outcome was looking at death versus death and or severe neurodevelopmental delay at 24 months, utilizing these liberal and restrictive. And I'll show the results in the next slide, but the key finding here is that there's no difference. There was no difference in neurodevelopmental outcomes at 24 months. There was no difference in sepsis or other issues during their neonatal stay. There was no real clinical significance in ROP, retinopathy of prematurity. And what that to me shows is that using a restrictive threshold and allowing patients is definitely safe. Another study that was come out is called the TOP trial, the transfusion of prematures. This looked at ELBW. These are babies less than 1,000 grams. And again, higher or lower hemoglobin transfusion threshold. And as you see on the right, for primary outcome, death or neurodevelopmental impairment, there's no clinical significance between the two groups. And even going through all of them, even from severe vision, severe hearing, there was none. And I think the key message that we could take, and the key message that I try to give off to my colleagues at other institutions, that babies will tolerate lower hemoglobin hematocrit levels, lower levels of anemia than we give them credit for. I think it is very difficult to sit there and it's very difficult to sit there and watch that. But I think if you take a look at the outcomes, it is quite apparent. And because one thing is that in neonatology, I heard this many times in many different talks about topics, is neonatologists were very quick to adopt different treatments. It's because we feel that our babies are severe. We're trying to do everything we can to them. And honestly, not many things are tested on premature babies. But we're very slow to change. And so once you get into a practice of doing certain ways and treating babies in a certain potential and certain modalities, and you see good outcomes, it's very hard to change. So you get into a situation where you're transfusing at higher levels and you see outcomes, decent outcomes, it's hard to change and try to stay away from that. So clearly, transfusing babies at a certain point is not the best path. There's no, and in many ways, there's no reason to do it. But we do, as I mentioned in the beginning, there are certain levels where they can't get past. And there are certain numbers where you have to say that a baby is at such risk for a neurodevelopmental delay that we would have to correct their anemia. But how do we choose a better path? How do we not get there? How do we not ever put ourselves in the point where we can say that we may be even having to talk about that? So I'll talk about quickly our experience at Englewood Hospital. First, as background, we're an 18-bed level, New Jersey here in the United States, level 3A neonatal ICU. And what that means is most of our patients have an expected delivery of 28 weeks or a birth weight of 1,000 grams. Are we taking care of all of ELBW babies at 24 weeks and 500 grams? No, we're not. However, we do have some, not very frequently. That's a function of both some of our restrictions, but also the fact that prenatal and perinatology has succeeded, that the numbers of babies born at those ages and weights are dropping. But with what's called a regional perinatal center approval, which is like the highest tertiary care, we are allowed to keep babies who are smaller or born earlier. We have a very good relationship with our regional perinatal center, and they trust us, so we do keep a bunch of patients. As well as we are allowed to make exceptions for our official blood management program. We do have an official blood management program where patients will be enrolled in at parents' request. However, the protocols and the policies and the thought processes within that program are what we use universally for all the babies in our NICU. There's really not much of a distinction in our minds, and there's really and not really done differently. However, to be able to keep some patients, we do sometimes enroll them. So certain things that we do, and I'll go into some detail in the next couple of slides. Early nutrition, very early, and we're seeing more and more. That's one of probably the key driver. The use of erythropoetin, the liberal use of erythropoetin, iron, making let me go back, and iron as well, making sure that we are using and maximizing the amount of iron that babies can tolerate to give them the building blocks and to give them the resources to try to, on their own, prevent a significant anemia that needs to be corrected. I'll definitely spend some time talking about erythropoietin. In the world of neonatology, it is still, for some reason, controversial. Some people don't fully buy the evidence, but I'm going to go through some studies to show that I think that the use is safe and clearly effective in many patients. So we have a protocol at Englewood Hospital for the use of erythropoietin. We test all of our babies. I know I talk about phlebotomy, but go back to that in a little bit. We do weekly hemoglobin, hematocrit, and reticulocyte counts to see how well they can do on their own and manage where we are in terms of their anemia. Our protocol is designed to reduce transfusion, both early transfusion and late transfusion. If we see a baby based upon prenatal factors, as mentioned before, ABO, RH, abruption, is going to be a risk for an early transfusion, because as they're just starting from behind the 8 ball and that their levels to start with are so low, we'll start early. We'll take a look at our premature babies, our babies at those 28, 29, 30 weekers. And some of them, given their own physiologic and pathophysiologic nature, will be at risk for a late transfusion, as well as those babies with ABO incompatibility who have such a high, or RH disease, who have such a high level of hemolysis that they'd be at risk for a late transfusion. And we would utilize erythropoietin. We have excellent results. Hopefully we'll publish some of them soon. Our usual protocol is 300 units per kilo daily for a 10-day course. We have used other ones. We have used some for sometimes the patients are about to be discharged a high dose, but that is the course we usually use. We test on Mondays, so we would start. Usually we would start it on a Monday. By the following Monday, we would begin to get results to see the first one that we would see is a reticulocyte count increase, hopefully going from 1% to 2% to the neighborhoods of 7, 10, even up to 12%. And then by the following Thursday, the course would be discontinued. But there have definitely been discussions in the neonatal literature about erythropoietin and about its use. So there was a Cochrane review in 2020 by Olson looking at early erythropoiesis stimulating agents in preterm or low birth weight infants. And what they found was that early administration of erythropoietin does not increase risk of death, does not increase risk of retinopathy of prematurity, which some of the earlier studies in the early 2010s had shown, and may decrease NEC, and it may decrease in neurodevelopmental outcome risk. Excuse me. It's important to show that these were some of the questions and issues that came up when the use of erythropoietin was first started in neonatology. And clearly, through meta-analysis, we're seeing that that may be incorrect. Additionally, there's been multiple trials showing safety and improvement. There was the Peanut trial in 2020, which looked at a high dose erythropoietin in 24 to 27 weekers. And while the results may not have shown, the results were somewhat controversial. So they said that they not show any change in neurodevelopmental outcome at 2 years of life. So some neonatologists took that to mean, well, if there shows no change in outcome, we shouldn't treat anybody with it. Others said, looking at maybe perhaps the endpoint of 2 years at 24 months, which is the classical use of looking at some neurodevelopmental outcomes in babies, that might not be the most appropriate time frame and endpoint to look at. And if you looked at 6 and 7 years, especially as children entered school, there were clearly improvements in neurodevelopmental outcomes for those patients treated with very high dose erythropoietin earlier. Olson, who also did the meta-analysis, there was a trial early on looking at morbidity and mortality as well, and they also showed again decreased IVH, intraventricular hemorrhage, and decreased NEC, necrotizing enterocolitis. Two key morbidity and mortality events that could take place in the NICU that could cause not just anemia, but really those are the key ones that cause harmful and severe neurodevelopmental outcomes and delays. Iron. So babies are definitely a decreased iron. So we are big proponents of early use of iron. both in our PO feeding babies, giving them iron supplementation starting at 4 milligrams per kilo, going up to or as high as 6 milligrams per kilo. We also use it in our TPN when we have babies who are on TPN. We'll use iron dextran to give them building blocks, and we definitely see safety and efficacy in our use of that. Like I said, we maximize it. In almost all babies, we maximize it at 4 to 6 milligrams per kilogram per day. And additionally, we don't tie it to EPO treatment. EPO treatment is a different tool in our armament for anemia, but we think that we really do need to provide for all babies and all of their building blocks the use of iron to help them correct the physiologic jaundice. And we continue it. It's not that we stop at a certain point. We send them home on it. We tell them that they need to be on it. We use it, and we make sure that our breastfeeding moms who may have a decreased risk are giving external forms of iron. When we have formula, if we have a formula mom, we use obviously iron fortified, and we keep going with the use of iron throughout the first year. Phlebotomy. So we talked about the use. So to reduce the risk from phlebotomy on our neonates, it has to be a joint project between neonatology and laboratory medicine. One thing I've always found during my career is that when you talk to other departments about small babies who need help, many people are very willing to put in extra effort to make sure that they can help them. We use small aliquots, as small as possible, for our testing. And one thing we are definitely big on in our division is test for information you need. Don't keep looking for tests. Don't keep doing tests just to be sure. And don't order whole panels when you only need one. For example, if we're concerned about a calcium level, don't order a basic metabolic profile, order a specific calcium level. They can be done on smaller, as well as if you start looking for one issue and end up with another, you're going to be having more and more phlebotomy losses. Early nutrition. I mentioned that before. We start on day of life 0. We would like to get every baby feeding as early as possible, hopefully by day of life 1. Yes, there are times when babies aren't potentially ready, but if we can get human milk, we will definitely start as within hours after birth. We increase consistently, but not aggressively. We truly stick to about 20, especially with our VLBW patients, less than 1,500. We stick to about 20 to 25 mLs per kilo per day of enteral feedings. However, but we're consistent. We like to reduce NPO days. We don't want to keep taking a baby on and off. That is not good for nutrition. Does not lead to a good nutrition profile. And what are NPO days? These are all these days that you get concerned that perhaps the feeding and the intolerance to feeding is a sign of something more systemic and more severe, and you hold off. So sometimes when we have rule out sepsis, especially when if a baby is showing signs of potentially being infected, people will make patients NPO. Obviously, if you are concerned for signs of necrotizing enteral colitis and the treatment is bowel rest, you would stop them. But it takes some being a little more liberal and not being super conservative to say, you know what, this baby may have a bloodstream infection and may have something else, may not be anything. We're going to start treatment. We're going to maybe do some tests, but we are not going to stop feeding. PDA treatment, this has been a real change throughout my career. It used to be, first of all, every PDA, patent ductus arteriosus, was treated in almost every neonate through the use of indocin, which definitely causes decreased blood flow to peripheral systems, including the gut. And you would make a baby NPO while you're on an indocin treatment. And indocin treatment can take 36 to 48 hours, of course. What we do now is, if we do need to, so first of all, a lot of more PDAs are not being treated. If a baby is showing signs of good perfusion and not allow what we call ductal steal, we will not even treat a PDA and we will keep watching. We may have a little bit of a fluid restriction, but then we can maximize calories within that fluid restriction. And if we do feel that we need to do a PDA treatment, what we will do is we'll hold our feedings, human milk or formula, at the point where they are. If they're, but not so, we will no longer increase over the next 36 to 48 hours, but we would definitely not make them NPO to allow for that nutrition and for the basic building blocks to be there. Another thing is feeding intolerance. Our babies sometimes have, especially those babies on respiratory support, show signs of spitting up, show signs of emesis. And instead of making a baby NPO for 24 hours, we'll hold the feeding, we'll put them on continuous feedings over a period of time, hopefully that we can continue that process. And what we found with early nutrition is that those are what make, I think what we're seeing is early nutrition and a great and positive nitrogen balance is probably what allows babies to tolerate lower levels of anemia and thrive and succeed. The last, and then one other thing we look at with nutrition is human milk-based diets. And this, while human milk-based diets, and what we're seeing, what we like to do is we would like to come to a point where an entire diet in for a neonate is human milk-based. That rely upon moms pumping and having breast milk, and sometimes we do use human milk banks. The unfortunate issue is that it is prohibitively expensive, and it can't always be done. But definitely, what we are doing too in our unit is for our most at-risk youth babies is putting them on a human milk-based diet, which is definitely easier to digest and will allow for less NPO. Phlebotomy. So, like I said, as I keep saying, it's been underappreciated, and what we do is we minimize tests. We really hold off on giving tests and trying to hold off as much as possible on blood work. One thing we're able to work with our respiratory division, our laboratory medicine, is using capillary blood gases with electrolytes. So those are sample size of 0.3 to 0.4. I apologize. 0.3 to 0.4 mLs of blood, and we're able to get both oxygen, pH, oxygen, carbon dioxide levels, and go ahead and get electrolytes and see where they are with their electrolytes. Cord blood, and a lot of what we use cord blood for now is for genetic testing. What we have found is that as the previous speaker mentioned, with pre-planning and knowing what needs to be done, we can get a lot of information off of the cord blood. And some of our genetic testing, those are the tests that are at 5 mLs, that require 5 to 7 mLs of blood. It's difficult to obtain, but really, if you take out 10 to 20% of a blood volume, it may definitely be almost impossible to really put them at risk of significant anemia. We also use H&H with retics. That's what we call them, hemoglobin hematocrit with reticulocyte count. It's a smaller amount than a full CBC and a full panel, and is what we need. And we found that the information we get from that is definitely able to make decisions based upon who would need treatments. Again, the overlying question is for us in our unit with phlebotomy and over the course of other NICUs is we ask ourselves, why do we need this? What will change? Are we going to do anything with the results that we get? And if we're not, then we really don't order the tests anymore to minimize phlebotomy losses. Delayed cord clamping. So this is definitely a newer treatment. 30 to 60 seconds. I know I'm not going to, I don't want to step on anybody's toes from the previous talk. I'm going to leave it to the obstetricians to decide exactly that this is what we see in some of our literature, 30 to 60 seconds of delayed cord clamping. And this is in all babies who are vigorous. So vigorous term and preterm infants. Obviously, if a baby is clearly in need of resuscitation, I think delayed cord clamping, while is definitely an option and not a requirement. But that's in term and preterm infants. And the studies are quite clear, something coming out of, I've seen in ACOG and other literature. Decreased transfusion, decreased necrotizing enterocolitis, decreased intraventricular hemorrhage. All those mean is decreased neurodevelopmental severe neurodevelopmental outcomes, as well as decreased amounts of transfusion-related injury, which is why we all know that bloodless is best, and also will lead to increased iron stores in patients, giving them again the building blocks to help correct their own anemia. One question does come up is jaundice, and while the evidence isn't as clear yet, there's definitely I hate the word, but trend that some of these patients are who have delayed cord clamping are more at risk for jaundice. However, if you work in a situation where you have a good bilirubin follow-up program, where you're able to follow babies and not lose them to treatment, that could be easily corrected with treatment of the very safe treatment with phototherapy lights. However, cord milking, and this is also from obstetrical literature and from neonatal literature, that isn't recommended. So really, to really milk the cord and get as much in as possible, it's probably not recommended. I think signs are showing it leads to increased intraventricular hemorrhage, and definitely in preterm infants should be avoided. Excuse me. This is all talking about what we can do as a healthcare team to reduce transfusion and practice bloodless medicine. However, a key part, and especially in the NICU, is relationships. And one thing that we have found is just talking to parents and treating them as equals. So while I said we want to treat all of our patients bloodless, and we basically give all the same care to all of our patients, we do have patients, obviously, whose beliefs and whose feelings will really feel strongly against the use of transfusion. And as I mentioned, there are certain points that we may have to, especially severe hemorrhages and severe anemias. So the key point is parental discussion involvement always. And what we have always found is to listen to patients and to hear what they have to say and listen to parents. And then from our perspective, say we understand and we're going to work with you every step of the way and keep you updated. Everything goes smoothly. And we don't like threatening. We like to do everything in a positive manner. And that's what we're known for. And that is what we see. And that's why we get patients coming to our care. And I can't stress enough, really, is to understand and treat them as equals and not try to play this heavy-handed role as that we're the treatment team and we know better. It doesn't work. It doesn't work in this, and it probably doesn't really work in any situation. So outcomes. So what have we seen any outcomes for allowing anemia, decreased transfusion? I mentioned before we have, but this is another study. This was published in 2020 by Kerpolani in the New England Journal. Looking at higher hemoglobin threshold and lower hemoglobin threshold, the two outcomes at discharge and at 2 years. And there is no difference. They use some of the cutoff that we mentioned earlier, 21, 24 hematocrits of 21 and 24. And what they're showing is that the use of a lower hemoglobin threshold and a decreased amount of transfusion and utilizing treatments such as Epogen and iron and all the management strategies that we spoke about, they're getting the same exact results. Now, some people, the naysayers, the pessimists would say, well, if we're getting the same exact results, it's not helping, but it is helping because transfusion has its own risks and own issues. And I think as we change more and more units, and the optimists in us talk about, well, we're taking away issues and we're taking away risks. And they did not look at them. They did not look at some of the real transfusion risks, the transfusion-related lung injury and GI injuries and things like that. And as well as potentially even donor issues of using the donors, we're seeing the same exact results, and therefore we should change our practices. I want to quickly, there may be another talk later this week, but I want to quickly just mention two specific cases that would just utilize and show how what we did. Cardiac surgery. So we don't have many, and we're not a cardiac surgical center, but we have had a case in the past where we had a patient who was in our bloodless program who was going to require cardiac surgery at 2 or 3 months of life, and working with our team and working with the parent and utilizing iron and bringing patients and putting them on erythropoetin courses and iron infusions, we were truly able to get the patient to a position where the hematocrit was over 40, which was the only place where the surgeon was willing to start taking into account to operate. I mean, they were willing to do it in a bloodless way as much as they can, but they were very concerned that to start off so low, how could they possibly do it? But working with the family and working with these treatments, we were able to do so. We were able to do that. And I mean, we've had a number of transfers. I put on here for my own notes, 28-week transfer. What this patient was, this was the first patient. I remember this. I'm not sure if Sherry remembers as well. This is the first patient we ever transferred from an outside institution to ours for a neonatal bloodless program. And it really goes through the entire gamut of what I spoke about. They were very upset that at their previous institution that they weren't listening to them, and they were talking already from the beginning, lawyers and court actions as they were really strongly opposed to receiving blood products. And they did their own research and they came to find out about us and bloodless. So the first thing we ever did with them was just sit down and just speak and ask and speak, hear their concerns and explain our concerns and say we will go through it and we will talk it through, and we will not wait until, and we're not going to go through this legalized fighting amongst us. We were going to be a team together. The patient was transferred over very early in life, and through the use of all the modalities, especially erythropoetin, iron and the TPN, as well as PO iron, or enteral iron when the patient was up to it, and decreased amounts of blood draws, the patient never received a blood transfusion. They were told at their previous institution that there was a 95% chance that they would have to. They never had one here. We saw her for 2 years in follow-up program. She was thriving, doing great, like any other 2-year-old would be. And it's just a success story of what we see when we take using evidence-based medicine and working with families to really manage neonatal anemias without blood transfusions. Thank you all for your time, and I hope this was helpful and informative.